So hello everyone, and I'll be starting a new series today, that is case study series, where I'll be discussing some interesting and thought-provoking cases for all the radiology residents out there, as well as other clinical branches like medicine and surgery. It will also help them in their approach to any clinical case. So starting, so here we have a 60-year-old male who's a chronic alcoholic, and he presented to the emergency department with severe colic type pain in the epigastric region, which radiated to the right upper quadrant, and he has been having this pain for the past 6 hours now. The pain was triggered by ingestion of a fat-rich meal and was associated with nausea and scleral icterus. In the emergency department, he was managed with antispasmodic, which decreased the pain. He also gave a history of jaundice 9 months back, which lasted for 72 hours with spontaneous remission. So, based on this clinical history, what are the differentials that come to your mind, especially for the medicine and surgical residents watching this video? So you usually think of alcohol-induced pancreatitis or cholelithiasis causing pancreatitis, acute cholecystitis. So accordingly, you proceed for the examination. So coming to the physical examination, so in general examination, that is pickle, scleral icterus was present, and on abdominal examination there was tenderness in the epigastrium as well as the right upper quadrant, but the Murphy's sign was negative on deep inspiration, that is ruling out acute cholecystitis as a possible cause of this pain. There was no fever, tachycardia or mental status alteration. Cardiopulmonary examination was also uneventful. Bloomberg sign was negative. Bloomberg sign is particularly rebound tenderness that is seen in peritonitis and appendicitis. That was also negative in this case, and normal bowel sounds were heard, and no visceromegaly was actually present on palpation. So based on these physical examination, what do you think the diagnosis is? The patient is having jaundice, and he's not having any features of acute cholecystitis or peritonitis, and he's having tenderness in the right upper quadrant and the epigastrium. So it still keeps pancreatitis as a differential for the pain abdomen, as well as obstructive jaundice because of some cholelithiasis or stone in the CBD. So coming to the blood investigations, a complete blood picture was ordered, and hemoglobin and hematocrit leukocytes platelets were normal. On LFT, ALP and GGT were raised, indicating obstructive jaundice. Albumin, PT, INR were all normal. Amylase and lipase were within normal limits, hence ruling out pancreatitis as a cause of this pain abdomen. So now we have ruled out peritonitis, cholecystitis, as well as pancreatitis as a cause. So what else do we think of now in the differentials? So still possibility of cholelithiasis or choledocholithiasis is there now clinically. So then they ordered an ultrasound abdomen. So here comes my role. So on ultrasound of the hepatobiliary system, there was diffusely increased ecotexture of the liver indicating hepatic steatosis. The gallbladder was well distended and echo-free with normal wall thickness and no pericholecystic fluid collection, hence ruling out cholecystitis and cholelithiasis as a cause of that pain abdomen. There was mild dilatation of the intrahepatic biliary radicals bilaterally, and the proximal part of the common bile duct was also dilated, measuring 10 mm in diameter. There was no evident calculus or mass seen in the visualized part of the common bile duct, and there was no abrupt cutoff of the CBD that was observed distally. So based on these findings, CCT abdomen and MRCP was advised for further evaluation of the hepatobiliary system. So so coming to the contrast enhanced CT of this patient, so these are the axial sections of that CT. Now we can see that there is some dilatation of the intrahepatic biliary radicals bilaterally that we can see. Mild dilatation of the CBD is also seen in these axial sections post contrast images. The pancreas appears normal. Gallbladder is fine. This is mildly dilated CBD. Look at the coronal images as well now. So these are the coronal images where we can see this dilated CVD, and there is some outpouching of the bowel that is seen here, which is causing compression of this distal CVD and upstream dilatation of the CVD as well as the intrahepatic biliary radical. So to get a better look, MRI was also done. In this MRI, we can see that the CBD is again dilated. There is one outpouching of the bowel that is seen surrounding the pancreas. The bowel that is surrounding the pancreas, the second part of the duodenum that is surrounding the pancreas, has an outpouching, which is causing the compression of the intrapancreatic CBD, causing upstream dilatation. So, based on this, what do you think the diagnosis is? A part of bowel, that is second part of the duodenum, has an abnormal outpouching causing compression of the intrapancreatic part of the CBD, causing upstream dilatation of the CBD as well as the intrahepatic biliary radicals. So on CT and MRI, there was a focal outpouching of the duodenum adjacent to the papilla, the second part of the duodenum, causing compression of the CBD, which was seen evidently on both CT and MRI. And it's called Lemel syndrome, which is defined as a obstructive jaundice caused by periampullary duodenal diverticulum compressing the intrapancreatic common bile duct with resultant bile duct dilatation. So actually the diverticulum, the duodenal diverticulum was the cause of obstructive jaundice here. So congratulations to everyone who got the diagnosis correct.